Hello, welcome everybody, and thank you to those who are joining us live and to those listening later. I would like to warmly welcome our guest today, whom I will shortly introduce. Our webinar today is titled Alcohol Consumption and Dependence, the Role of Pharmacists in Prevention, Support, and Management. Worldwide, around 2.6 million deaths were caused by alcohol consumption in 2019, with 1.6 million of these resulting from non-communicable disease, according to the WHO. These webinars explore the burden of alcohol consumption and the complex relationship between the alcohol addictions and various diseases, including non-communicable disease, emphasize the importance of the early intervention, support, and effective management strategies. Today, you will learn about the WHO Safer Initiative and how, as a pharmacist, can we play a crucial role in prevention, support, and management efforts, collaborating with healthcare teams to improve patient outcomes and reduce the alcohol-related health risk. Today, the Turkish Pharmacists Association offers a Turkish translation. It is available on the Zoom by clicking down on the translation icon. My name is Leticia Caligaris, and I am the professional secretary of the CPS, the Community Pharmacy section of FIP. I am very happy to be here with all of you. Okay, now we are going to have some announcements. Please note that this event will be recorded, live streaming on FIP YouTube, and the recording will be available at event.fip.org. Please feel free to send your questions, thoughts through the Q&A box, and I'll do my best to manage them so we can address them all at the end. You are welcome to provide your feedback to our email, webinars@fip.org. I would like to take this opportunity to the benefits of becoming a member of FIP, including these digital events and webinars. FIP is the global body representing over 4 million pharmacists and pharmaceutical scientists. If you are a pharmacist or pharmaceutical scientist and you would like to become a member, please register on FIP's website at fip.org. For this event, we're joined by a panel of fabulous speakers, and I want to sincerely thank each of them for taking the time to prepare the presentations. We are going to have some to read our program. We are now in number 1. We are in then we are going to have addressing the global burden of alcohol use, the World Health Organization Safer Initiative, and we're going to have Dr. Doug Rekve. He is a senior technical officer, alcohol, drug, and addictive behavior of WHO. Then we are going to talk with, to have the conversation of talking with patients about alcohol, opportunities and challenges for pharmacy practice. And we are going to listen to Dr. Professor Duncan Stewart, Professor of Applied Health Research, London Metropolitan University, United Kingdom. Then we are going to go to the role of pharmacists in identifying individuals at risk of alcohol dependence through screening tools. And we are going to listen to Dr. Romeo Ongpoe, Junior Director of the Department of Science and Technology in Philippines. Then we are going to have the pharmacological intervention and medication management for alcohol dependence. And we're going to listen Dr. Corina Scooter, Head of the Department of Pharmacology and Clinical Pharmacy at Nicolae Teminau State University of Medicine and Pharmacy in Moldova. We are going to pass through the Q&A, and we're going to have a wrap and conclusions. What are our objectives today? Well, we're going to understand the burden of the impact of alcohol consumption on the development of the non-communicable disease and other health problems. Learn about the WHO Safer Initiative, explore prevention strategies that pharmacists can implement to reduce alcohol-related harm in their communities, learn how to develop comprehensive support and management plans for patients struggling with alcohol dependence, including counseling, techniques, and medication management. And the last, we are going to explore the effectiveness of pharmacists delivered primary care telemedicine intervention to increase access to pharmacotherapy and specialty treatment for alcohol use problems. Okay, now we are going to listen Mr. Doug Reck. He is a senior technical officer and acting unit head for alcohol, drugs, and addictive behavior at the WHO. With a master's degree in business and economics, he has over 30 years of experience across local, national, regional, and global organizations, including the treatment sector, civil society, and governmental organizations. Doug has led the initiative like Safer in WHO, global status reports, and alcohol and health driving evidence-based policy to reduce harmful alcohol use. His work focused on cross-sectoral collaboration, capacity building, and aligning policies with the Sustainable Development Goals, shaping WHO policy agenda and over the past 2 decades. Please, Dr. Dell, the floor is yours.
Thank you very much, Latisa, and good morning and good afternoon. It's a great honor to have been invited to this webinar from the Pharmaceutical Federation. It's really an important issue to see how different groups in society can contribute to reducing the harmful use of alcohol, and I think pharmacists and the pharmacists play an important role here, and we will come back to that later. First, I would like to give you an overview of what is the situation with the global burden of from harmful use of alcohol, and look into what kind of interventions we can use, and especially focusing on the safer package and the safer initiative, where I think there are many contact points with pharmacists around the world. So WHO is the specialized agency in the UN system for health, and we have a specific mandate both to develop policies, to give normative and standard setting guidance, prevention strategies, treatment strategies, and also monitoring and evaluation. So we are working with all the different aspects of alcohol and the negative consequences from alcohol from a health perspective. And here you see just some of the documents and decisions that our member states have endorsed the last 20 years. First of all, the global strategy to reduce the harmful use of alcohol from 2010. Then the NCD Global Action Plan from 2013, which is extended to 2030, which lists alcohol as one of the main risk factors for non-communicable diseases. And we have the Global Alcohol Action Plan, which also is a WHO document endorsed by member states from 2022 to support the implementation of the global strategy. And not the least to mention that in 2015, the UN family in the UN General Assembly agreed that under the Health Goal 3, prevention and treatment of substance abuse, including harmful use of alcohol, is an integral part of the sustainability agenda. And as such, we have developed a safer technical package to facilitate all these political documents, to work with countries to introduce effective strategies and interventions to reduce our harmful use of alcohol. But I think we first need to come back to base. And you as pharmacists, you know this, even though many don't really like to hear it. But ethanol is a psychoactive substance, which at least 3 key effects which are related to health. It is toxic on many tissues and organs in the body. It is intoxicating and makes us do things that we would would not do if we hadn't been drinking alcohol. It's also slowed down our cognition and our motoric abilities. So, and through the intoxication, it also creates a lot of harm. And finally, it has dependence-producing propensities, whereby the drinker's self-control is also reduced, and it creates its own demand when you have went into dependency. And this is what we need to keep in mind when we talk about alcohol. It is a psychoactive substance, and that is the starting point. Of course, we all have all our views on why do people drink, and we have every aspect of science and every aspect of individual thinking is linked to, and probably each and every one of us have our individual views on why people are drinking. It's a lot of reasons why people are drinking, and many of them are philosophical without any real evidence behind them. Others are just intuitions or loose thinking. What I think we need to keep in mind is that, first of all, many psychoactive substances have important medical applications, but they are not essential for daily life. So their use and non-use are often then a matter of personal and cultural choice, at least until dependence kicks in and overrides both the personal and individual choices. And we try to put this into a system to understand what are the pathway into what is the main issues for WHO. And that is the mortality and disability by cause, the socioeconomic consequences, and not least the harms to others, which is really an important part of alcohol-related harm, which are just recently starting to really uncover and find out more numbers around, because that is very tricky. And as pharmacists, you know that this is the main issues, the propensities of the substance at hand, the ways and means of how it's administered, and then the level, pattern, and context of use. And that then creates the health outcomes with either chronic or acute. And behind here are all the different drivers. And what our focus is on in this box. We know that this is very important. We know that biological factors, sex, and potential increased risks from predispositions from genetic factors are important. We know that psychosocial factors are important, and socioeconomic factors are important. At the same time, at the social level, the level of development culture are also important. But we are working here with prevention, treatment, and harm reduction policies and programs, and the availability and affordability of substance use. Of course, we would like to work on all these other factors, but we need to go where the evidence is telling it that it had a direct impact on alcohol-related harm. And those are in these two boxes in this side. I don't want to go into detail here, but we have to have three different aspects on the harm in mind. We have to have the negative consequences of the use itself, then the negative consequences for users and for others on the way that we are trying to control the use, and then the problem with lack of availability for medicinal, therapeutic, and scientific purposes. And these are often seen as competing goals, but our task is to try to balance them in a way that reduces the overall harm from the psychoactive substances. And that is our task at hand, and not trying to pick one of them and highlight that in our whatever aims we have for policy, for example. And the WHO in the global strategy in 2010 clearly focused on, manifested that the harmful use of alcohol is broad and encompasses the drinking that causes detrimental health and social consequences, not only for the drinker, but for the people around the drinker and society at large, as well as the pattern of drinking that are associated with increased risks of adverse health outcomes. So it's a very broad definition of what is harmful use of alcohol. It's not only, those of you who know ICD-10 and ICD-11 knows that there is a specific diagnostic criteria in ICD-10 about harmful use of alcohol. This is a political consensus language which is much broader. And the effects on society is huge. Alcohol is clearly one of the key risk factors for the burden of disease, with 2.6 million deaths that Leticia already mentioned. Considerable disability-adjusted life loss due to the morbidity, and also that 400 million adults worldwide are living with an alcohol use disorder, and almost half of them with dependence. We know that there are considerable gender and geographic differences, and that it hits young people mostly, and especially, and that in fact that most adults in the world do not drink alcohol for many different reasons. And we know that there are considerable negative health and social consequences for other than the drinker. And per capita alcohol consumption here is, we have just this summer released a global status report on alcohol and health, and you can go on our webpage and download that, and you will find all the statistics I referred to here and get a broader perspective. But the per capita consumption is often a good indicator for alcohol-related harms. And here you see how the development has been the last 25 years in different regions. We are fairly stable at the global level, while Europe are continuing decreasing its consumption. Southeast Asian and the Western Pacific has had a sharp increase, but now during COVID, and COVID has had a huge impact on overall consumption. We don't know if that is something that will continue or it will be bounce back. Most likely it will bounce back. This is another perspective to look at indicator for alcohol-related harm, and that is heavy episodic drinking. And that is an extremely important indicator. The problem with that is that it's not very reliable compared to per capita alcohol consumption. But here you see the level of really harmful drinking, especially in males. And you see the difference between different regions. So Europe and the Americas, really a lot of bad patterns on drinking. But even in countries with high levels of abstinence, you have high also detrimental drinking patterns. And here are all the diseases, well, the key diseases that we have been able to estimate the burden on, and which is clearly detrimental. For most of the diseases, alcohol is detrimental. Only for a few diseases, they also have a beneficial impact on the diseases. But overall, it's clearly detrimental. And the 2.6 million deaths, that are net effects when the beneficial effects are subtracted from the gross effects of harmful use of alcohol. A way of looking at this is how alcohol affects different diseases. What are the attributable fractions on the different diseases? Or you can see how it is distributed inside alcohol, how the different diseases distributes itself. And there's a lot of things we can learn about here from to looking at where we should intervene and how we should intervene. We have a lot of knowledge about the problems, we have a lot of knowledge about the solutions, and we have also clear global decisions on this. So what we need to do now is to have action at all different levels. And we introduced, I will not go through this, but we have had a lot of issues with implementation thus far. And many inertias, many obstacles, and which really we need to work on. And the way we try to work with all these different obstacles is through what we call the Global Safe Initiative, which was launched in 2019, where we work with different sister organizations in the UN and with civil society, and of course our member states, to try to implement high impact strategies. And with high impact strategies, we mean those that really has evidence behind them that they affect and reduce alcohol-related harm. And that is to strengthen restrictions on alcohol availability. It's to advance and enforce drink driving countermeasures. It's to facilitate access to screening, brief intervention, and treatment. And I hope we can talk much more about that a little bit later, because here is a clear entry point directly for pharmacists. Enforcing ban and comprehensive restrictions on advertising, and raise prices to alcohol and through excise taxes and pricing policies. And pharmacists, of course, can contribute to all these 5 interventions, but especially on the facilitating brief intervention and treatment. And we work very heavily with countries. We try to institutionalize alcohol policies at the country level, but it's extremely difficult. We are competing interests inside the health, and many of the effective interventions are outside of health. There are many competitors, even inside the cabinet, who don't want to put these effective interventions in place. So this is a very, very difficult work, but we have some really good experiences working in a couple of countries. on it. But I would just like to highlight a couple of the counter forces. So we are working in Uganda, but what in illicit drugs and in tobacco, we talk about crop replacement. What we have seen in Uganda is crop in placement. Then, in fact, Uganda was not producing raw material for beer, commercial beer. They produce, of course, for informal beer, but not for commercial beer. And that started in 2002. And they got a lot of subsidies, and they were making the farmers dependent. Now 30,000 farmers are dependent, and they are the breweries are the bigger taxpayers in the country. And the UN family is, in fact, promoting this as a good supply side initiative. And what we see now is that the farmers are very important lobbyists in trying to prevent the implementation of effective strategies this year. And the bill on alcohol in Uganda was killed partly with the help of the lobbying from the pharmacists. Not from the pharmacists, from the farmers. Yeah? And we had hoped that pharmacists could have been on the table on the other side there. It would have been very helpful. In Nepal, we also are working heavily. They have a total ban of alcohol advertising. That was totally ignored. The biggest brewery in the world used another country where alcohol is banned or heavily restricted to a championship there to penetrate the Nepalese market using all aspects of modern marketing techniques and disregarding the total ban on alcohol advertisement in Nepal. So this is just of the couple of the obstacles we are facing. So the lessons we have learned is that you really need local ownership and decentralized ownership in this. You cannot ask people to do things on your behalf. We also see there's a lot of different structures and inertia in the structures and coordination, varying narrative. We all have our personal views on alcohol. So how to create a unified narrative so we don't start discussing against each other, even though we have the same goals. We see commercial determinants and corporate interests, how evasive they are, especially in lower middle-income countries, but also in developed countries. And addressing these challenges needs really a concerted, coherent public health approach and a long-term financial planning, and then to ensure sustainable implementation. And this is not something you can do with the left hand, and you need to have many with you. You cannot do it alone. And that's why it's really a great pleasure to be here today in this seminar. And so the way forward, we need to work at all levels. What the level I'm not mentioning here is the individual level, but that is extremely important because we all have to go into ourselves. We have to do our introspection. What kind of place do we want alcohol to have in our society? How important is it for us when we see all the trouble we have? Can we at least support some policy interventions that are effective, even though we don't want anyone to take alcohol away from us? And this introspection in our own minds are really important. At the local level, we need to engage communities and tailor interventions to the local context. The national level need to develop and enforce comprehensive policies. Often these policies have competency at the local level also. Allocate necessary resources and support public health initiatives. At the regional level, we have to facilitate coordination and harmonization of policies across countries. And cross-country learning and networking are really important in this picture. And finally, at the global level, we need to strengthen the evidence base, provide normative guidance, and advocate for strong policies and support international collaboration and get more international organizations involved in it. And resource mobilization on all at all levels, it should say. Yeah? This is important, and through excise taxes, in fact, we have a possibility for getting sustained financing to it, but it's extremely difficult to get that through. So this was just a quick introduction into what WHO do on alcohol, what are the global burden from alcohol-related harm, what are the effective interventions that have an evidence behind them, and how we now are trying to utilize the SAFER initiative to really make an impact and a difference at national and local level. Thank you very much for your attention.
Thank you very much, Dal. Now we are going to move to Professor Duncan Stewart. Duncan has a background in sociology with long-standing research expertise in treatment approach for people with drugs and/or alcohol problems. More recently, he has been working with pharmacists in community pharmacy and general practice to integrate attention to alcohol into the routine reviews of medication. Please, Duncan.
Thank you so much for the introduction, and it's great to be with you all today. I'd also like to thank Dag, because that was the perfect backdrop to what I'm going to be talking about for the next 10 or 15 minutes, which is how pharmacists actually interact with patients when they're talking about alcohol, and some of the opportunities and challenges that presents for pharmacy practice. Next slide, please. So the focus of my talk is on brief interventions for alcohol, by which I mean short, structured conversations about alcohol, and that could range from a few minutes to a more substantial period of time. I'm going to introduce you to some findings from a 6-year program of work we've been doing here in the UK with community pharmacists and also pharmacists who work in general practice in England. And this work's funded by the NIHR in the UK. Next slide, please. So the starting point really is what we already know about brief interventions for alcohol. So most of the evidence comes from primary care, but not exclusively so. And it shows modest, generally short-term reductions in drinking after screening and a brief intervention for hazardous alcohol consumption. So it demonstrates broadly evidence of efficacy, but the real challenge is translating that into routine practice. And we know from effectiveness trials, so trials done in, or as close as possible to conditions of routine practice, the findings are much less clear in terms of whether brief interventions are indeed effective. And we actually, when you look at the evidence in detail, we don't really know very much about how brief is better, what kind of intervention content works best for whom and under what circumstances. And finally, one of the real difficulties with implementing brief interventions is that they're often not done. So opportunities to intervene are missed. And that's primarily because alcohol remains such a difficult topic to talk about. It's difficult for practitioners and it's difficult for patients. So opportunities for intervention are often missed. Next slide, please. So, for the starting point for our research was just reflecting on the extended roles for pharmacists in the UK and elsewhere, particularly around promoting and protecting public health, and smoking cessation is a very good example of the extended roles of pharmacists in recent years. And we just thought, well, that should really include alcohol too. So there was a trial of a brief intervention delivered by community pharmacists in London. And to cut a long story short, it found no effect for the intervention. So consistent with some of the more recent trials of brief interventions in routine practice delivered in primary care and general practice, we found no effect. Next slide, please. And actually, when we looked at this in more detail, there were clearly low levels of knowledge amongst pharmacists about alcohol and broader issues in behaviour change. The research also identified variations in the communication skills amongst the participating pharmacists, and actually quite significant learning needs in terms of addressing that deficit. And overall, we concluded actually it was a lot to ask of pharmacists to deliver this kind of intervention in conditions of routine practice. And actually, we probably have to go back to the drawing board with recent interventions and rethink really the content of those, the delivery of those, and how we support practitioners, in this case pharmacists, to implement this kind of intervention. Next slide, please. So we took a step back really and thought about alcohol problems more broadly and what it means in terms of practice in primary care. And I think we were sort of thinking, well, why do we only focus on people with the most severe problems? And what about the harms associated with alcohol more broadly? And particularly in primary care, we were thinking of the growing number of people with long-term conditions who are prescribed often multiple medications for those conditions. And it's, alcohol will interfere with the effectiveness of those treatments. And surely that should be part of the conversation about alcohol. And so we started to be orientated more towards a kind of prevention approach to discussing alcohol with patients in primary care settings. Next slide, please. So we've been working with pharmacists to develop a new approach to brief interventions. And this is sort of a summary of the main elements of that and how we've gone about designing this intervention. So thinking about how we could integrate attention to alcohol into routine medication reviews. So thinking about the role of the pharmacist in community pharmacy or in primary care, delivering medication reviews to patients who are being prescribed multiple medications and for whom, even small amounts of alcohol could actually be interfering with the way those medications work. So the first thing we wanted to highlight and focus on was the idea as alcohol as a drug and making that explicit. And if you think about alcohol as a drug, alongside the other drugs that people are being prescribed, for their health conditions, then it leaves pharmacists actually very well placed to discuss alcohol in that context. And it also gives pharmacists legitimacy to introduce alcohol to patients because pharmacists, as we know, are experts in drugs. And in that way, attention to alcohol could be integral to the core role of pharmacy professionals. The second thing we wanted to avoid is the tendency to moralize when discussing alcohol, sort of uninvited advice giving, telling people off for drinking too much. Instead, stemming from this idea as alcohol as a drug, using that as an opportunity to help patients think through how drinking affects their medicines and their conditions and their health. And if you do it in that way, the discussion might only briefly focus on alcohol for most people, but of course for some people that would be quite a significant element of the discussion. But the idea is to help patients think through these things themselves rather than the pharmacist owning the agenda of that consultation. So relatedly, the challenge for pharmacists is to skillfully engage with issues that are raised by the patients themselves. So delivering that person-centered consultation. And actually, given the findings we had from the London trial and from discussions with pharmacists and patients in the early phases of this research, it clearly required substantive training and practice development to get pharmacists in a position to be able to have this kind of more nuanced discussion of alcohol. Next slide. So what do patients and pharmacists think about this idea? Well, when we spoke to patients, they actually quite liked the idea of alcohol as a drug and how it helps them think about their medications in a different way. This quote refers to the MAC, which is the name we've given to our intervention, the medicines and alcohol consultation. But it really it seemed to be an effective way of helping people to think about their drinking in a different way. So rather than thinking it of themselves as having a drinking problem, which for most people was the way they conceptualized alcohol as a problem, they were actually quite willing to reflect on their drinking and how it might actually be affecting the way their medicines are impacting on their health conditions. Next slide, please. Similarly, for pharmacists, it seemed to be a kind of almost a light bulb moment for many of them, that actually they hadn't really explicitly thought about alcohol as a drug. And when they did so, they sort of wondered why they, as this quote points out, it was a striking omission. And they really quickly began to see ways in which it was relevant to discussing medicines and conditions with their patients in a way that they hadn't done previously. Next slide. So we run a number of studies to train pharmacists. More accurately, we prepared a practice development program for them. We've implemented this in community pharmacy and in general practice as well. And these are just some reflections on how well that has gone. So we have actually observed quite clear changes in practice. A shift from that uninvited advice giving, that almost impulse to interrupt and to give advice about alcohol. They've stopped doing that, and let the consultations and the discussions have been much less driven by the pharmacist agenda. So you will know that often these medication reviews are structured around what the pharmacist wants to talk about, and what we've tried to do is to give more space to understanding what the patient wants to talk about. And actually, when we've done that, there've been more conversations about alcohol, which actually come from the needs and the experiences of patients themselves, without the pharmacist actually having to do much digging. And that's sort of helped the conversation flow in a way that we think it probably wouldn't have happened under the traditional brief intervention model. Now, we're not claiming this is perfect by any means, and actually the major reflection is that it takes quite a bit of time for pharmacists to change their practice, and that's completely understandable. In particular, active listening skills take time to acquire and to kind of embed into routine care, and really being attentive to what matters to the person in front of you. Similarly, being able to respond to those needs in the often limited time available during a medication review. We understand that pharmacists are time pressured, and sort of being more relaxed about that and using the time differently is a challenge, and being able to respond to patients' needs in that context is difficult. And finally, just being attentive to opportunities to introduce alcohol where relevant. We found that they were getting there. They're doing much more post-treatment than they were post-intervention than they were pre, but there was still some way to go in spotting opportunities where alcohol might be something you could introduce into the discussion. Next slide. So I'm going to end the talk really with kind of a new agenda for brief interventions for alcohol, and this isn't shameless self-publicity, or it might look like that at the moment. But what we really want to do is to kind of reflect on these findings and think about what it means for brief interventions and prevention more broadly, including the potential role of pharmacists within that. And I think really the main point to make is that, why should these interventions just be about how much someone drinks? I think this is kind of the hub of the issue for us. Actually, there's so much more to talk about. Now, in this particular intervention, we've flagged up the issue of alcohol as a drug because that's salient to the context of a medication review. But there are other things that brief interventions could address. Some of the things that Dag was talking about earlier, some of the social influences on drinking behaviour, such as alcohol marketing or pricing, etc., or the cultural norms or stigmatizing attitudes towards alcohol. These are other things that we could perhaps usefully talk about with our patients. And so this paper is just a kind of a provocation, really. What we're doing is saying, well, look, brief interventions needs to change, and we've made some suggestions as to the directions of travel for this kind of intervention in the future, without really presenting much in the way of solutions. What we're doing is saying, well, look, this is a conversation that we, the scientific community and practitioners, pharmacists and other healthcare professionals really need to be having if the contribution of brief interventions is to realize its potential. In other words, to actually bring about population level changes in alcohol consumption. So I'm going to end my talk there. Thank you very much for the opportunity to introduce you to this research. I look forward to answering any questions you might have a bit later on.
Thank you, Duncan, for your presentation. Without a doubt, in community pharmacy, we face a significant challenge in addressing patient alcohol consumption. Now we are going to listen to Romeo Ongboy. Dr. Romeo is a licensed pharmacist from Philippines. He is currently in government service as director of the Department of Science and Technology in the Mimaropa region, and finds time also to be a volunteer in the local government unit care of AHV screening and substance use screening. He completes his DBA at Emilio Aguinaldo College in Manila, Master of Science in Pharmacy at Centro Escolar University, and BS Pharmacy at Southern University. His experience is versatile and previously has been working as a dean regulatory professional, clinical specialist, and grew up in community pharmacy. Please, Romeo, the floor is yours.
Good day. My name is Romeo, and I will be discussing on the roles of pharmacists in identifying individuals at risk of alcohol dependence through screening tools. Next slide, please. I am a pharmacist with a master's and doctorate degrees. I also have postgraduate diploma on substance use interventions. I am also a volunteer for cancer care, HIV testing, and substance use intervention. Next slide. This presentation aims to give an overview on the screening tools for alcohol dependence that may be used at the pharmacist level. I will discuss each of these tools and share some interventions that may be done, as well as other ways to help in alcoholism. Next slide. Next slide, please. In this presentation, the alcohol use in the Philippines will be given an overview. I will then discuss the audit, or alcohol use disorders identification test, ASSIST, or alcohol smoking and substance involvement screening test, and ASI, or the addiction severity index. Discuss as well common intervention tools at the pharmacy level, and lastly, the importance of building a referral directory. Next slide. So the Philippine literature in alcoholism revolves around its use among the youth, particularly the students and the women, being a feminist country. It tells us that drinking alcohol has been the norm for a Filipino youth, and that even women in their prenatal age drink alcohol due to misinformation that traditional alcoholic drinks, like for example, tuba, do not contain alcohol. The females also play an important role, a critical role in regulating alcohol use, specifically the wife when they talk to their husbands about alcohol. Overall, there is a need for more studies in the Philippines for alcoholism, as there is not enough literature to capture the current situation. Next slide. To be able to be effective in screening patients for alcohol problem, a pharmacist must be able to understand the Jellinek curve. This tells us about the phases of addiction. According to this curve, there is a progressive phase where the alcohol use is for relief, but then tolerance develops, unfortunately. Crucial phase happens next, where the use of alcohol increases and problems from its use start to emerge. Then you also have chronic phase follows. It is when problems mount and control disappears. So the rehabilitation phase follows, and this is when the pharmacist initiates or starts to bring back the patient to abstinence and help them sought help. And therefore, our role as pharmacists is very important as an aid to alcoholism. Finally, we have the recovery phase. This is the last phase where the life of the patient improves and hope is restored. By understanding these phases, the pharmacist knows when to be of use and develop overview and empathy to what the patient is going through. Next slide. We also need to understand the change model. This has been used for a lot of things, including pharmacist-led smoking cessation program. For a quick review, pre-contemplation stage is generally when patients are not yet thinking about quitting their alcohol, so we cannot push too much when they are not ready. Contemplation stage is a good stage for the pharmacist to introduce the alternative of seeking help for alcoholism. This may easily be incorporated to the result of the screening tools, including audit, assist, and ASI. Preparation stage involves making small steps towards quitting alcohol, and the pharmacist can support the patients with some of the tools I will discuss later. So the action stage is when real change take place, and pharmacists can also be part of this stage with the patient. Maintenance stage is when we help patient maintain healthy behaviors away from alcoholism. And when the patient relapses at the relapse stage, a pharmacist should be able to make the patient feel less demoralized by showing the advantages um, of changing. And then in this slide, the pharmacist needs to understand the stages of alcoholism as part of the clinical team that operates through clinical findings. Stage 1 will give the patient mild withdrawal symptoms, including anxiety, sweating, headache. And stage 2 will give the patient moderate withdrawal symptoms, including increased blood pressure, irritability, and irregular heart rate. Stage 3 will give severe withdrawal symptoms, including intense sweating, fever or feverish conditions, and severe agitations. Lastly, post-acute withdrawal symptoms that persist for months includes anxiety, depression, and even sleep disturbances. Understanding these stages will also help the pharmacy offer OTC medication to help in the alleviation of the withdrawal symptoms and be more understanding during the screening process. Next slide. Next slide, please. So these are the tools for screening alcoholism. But for this presentation, we will only focus on these three. Audit identifies the problem related to the use of alcohol. Assist to evaluate the frequency of problems for alcoholism and other substances. Lastly, we have ASI to assess in a multidimensional approach for the severity of the alcohol problems as well as that of the other substances. So go to the next slide. Thank you. So alcohol use disorders identification test, or the audit, is the commonly used tool in adults to screen for harmful alcohol consumption and usually the initial step to evaluate alcohol-related problems and risk. This tool is a 10-question instrument to identify persons with hazardous and harmful patterns of alcohol consumption and dependence, then objectively determine the initial symptom severity. This later provides a framework for intervention to help risky drinkers reduce or cease alcohol consumptions and thereby avoid the harmful consequence of alcohol drinking. Next slide. So this is how audit looks like. The audit question 1 to 8 may be rated from 0 to 4, while questions 9 to 10 may only be rated 0, 2, and 4. The corresponding domains of each questions are shown in the slide. Like question 1 deals with the frequency of drinking, question 4 is about impaired control over drinking, and question 9 is about alcohol-related injuries. As can also be seen, questions 1 to 3 deals with alcohol consumption, questions 4 to 6 are about drinking behaviors and possible dependence, and questions 7 to 10 are about the consequences of drinking. The next slide, please. So this is the scoring system for audit. So after scoring each of the questions, summing them up would give the total score, where 0 to 7 means low risk and will require brief education. 8 to 5 means risky or hazardous level, where brief intervention may also be needed. 16 to 19 means high risk or harmful level, where another brief intervention may be done, but with referral to a specialized treatment facility. Lastly, above 20 means high risk, where there is definite harm with possibility of dependence, and in this case, immediate referral to specialized treatment is actually needed. A high-risk behavior is also a prompt to further screen for dependence using other screening tools, like for example, ASI. I will discuss later on. Audit is very much accessible online and may be accessed through the link shown on the top of the slide. Thank you. Next slide. Then another tool would be the WHO's ASSIST. So ASSIST is a tool developed by WHO, like what I've said. It stands for Alcohol, Smoking, and Substance Involvement Screening Test. And it's an 8-item questionnaire that measures an individual use of alcohol, tobacco products, and other drugs across his or her lifetime and in the past 3 months. Each of the questions correspond to certain domain, like question 1 is for the lifetime use. Question 2 is for the current use. Question 3 is for dependence. Question 4 to 6 are for problems. Question 7 is for dependence. And question 8 is for risk. Grading for questions 1 are 0 to 1. Grading for questions 2 to 5 are 0 to 4. And questions 6 to 8 are 0 to 2. Next slide. So the substance being assessed for assist are tobacco products, alcoholic beverages, cannabis, cocaine, amphetamine type stimulants, inhalants, sedatives or sleeping pills, hallucinogens, opioids, and other substances like cough syrup. So it's not only alcohol. If the overall score falls within 0 to 3, no intervention should be made. If the overall score falls within 4 to 26, brief intervention is needed. And if the overall score is over 27, more intensive treatment should be sought. There are specialized attention given though for those who inject drugs, where more than once per week or 3 or more days in a row of injection needs more intensive treatment. Next slide, please. So in the Philippines, we have a local version of the WHO Assist that has been translated to Tagalog, which is our native tongue or language. And we use this for those who have difficulty in speaking English and for those who prefers the local language. Next slide. So next slide is the third tool that I will introduce to you. This is the ASI. Now, this is a 45 to 60-minute semi-structured interview administered by trained clinician or interviewer who must spend another 10 to 20 minutes scoring it to elicit the respondent's self-reported problem. So it's quite long. The following are the areas being assessed: medical, employment support, drug and alcohol use, of course, legal, family, social, and psychiatric. It covers the last 30 days and lifetime of experiences of symptoms and treatment in each of the treatment areas that I previously mentioned. So the right treatment plan may eventually be identified in each of the domains of the physician, by the physician. In the Philippines, we always refer to the physician as it is the most appropriate thing to do legally and with the lack of current addiction professionals from other professions. Next slide. So ASI looks like this, if you can see on the screen. So where the first page gives instructions to the interviewer, half-time rule is applied, and half-time rule is where 14 days or more is regarded as a month, and 6 months or more is considered 1 year. So you need to round it off. A list of street names of substances is also provided so that common understanding is facilitated, as well as easy understanding of many common names of drugs. There are also certain pointers given for alcohol-based screening, like regular use is regarded as more than 3 times per week. So that's how ASI defines it, more than 3 times per week. That's considered regular use. A patient may respond 0 to 4 to be graded in a standard manner. And there is also an interviewer rating where 0 to 1 is interpreted as no real problem. 2 to 3 is interpreted as slight problem. 4 to 5 is moderate problem. 6 to 7 is considerable problem. And 8 to 9 is extreme problem. The severity profile may then be used for the referral to the appropriate professional from the pharmacist. Next slide, please. So ASI is actually used for clinical, administrative, and research purposes. Like in summarizing the patient's overall status at treatment admission, that is a clinical use. Evaluate and compare treatment program for administrative use purposes. And measure treatment outcomes, well, that could be regarded as a research use. Next slide. So since ASI is very long, it takes about an hour to finish. I will just give sample questions at ASI. To assess medical status, a question like how many days have you experienced medical problems in the past 30 days are being asked. While assessing employment support status would ask questions like how many people depend on you for the majority of their food and shelter. Next slide. So an example of legal status question is that how many times in your life have you been charged with driving while intoxicated? And an example of family social relationship is, do you live with anyone who used non-prescribed drugs? And to assess psychiatric status, like how many times have you been treated for any psychological or emotional problems are usually asked. So let's go to the next slide. So this slide talks about, from this slide, it talks about the interventions of pharmacists. So while referral to the physician is usually being done, there are some immediate things that a pharmacist may do for the patient as a value-added service. So next slide. So identifying cognitive distortions is one, where the distortions are identified with the corresponding frequency. You can see that an example of that is your all or nothing, overgeneralization, so on and so forth. An example of a cognitive distortion is, another thing is mind reading, where the patient or the client, as we term in for clinical use, assumes that someone is reacting negatively towards him without finding out facts or emotional reasoning, where how one feels is assumed to reflect how things are. So those things, they are called your cognitive distortions. And what do we do with them? Next slide. Next slide, please. So what we do with them is that the negative thought may be identified and later classified as to which type of cognitive distortions. Then talk to the client what would be a rational response to help remove the negativity. So we take that out from the patient, hopefully. And then keeping a thought record is a good way to track the change and change the distortions that can be very helpful to bring to the mental health professional. So it is actually a good thing if you refer somebody to the mental health professional. This can be a good help for clients that are usually negative or confused in changing their alcohol addiction status. Next slide. So another thing that can be done at the pharmacy level is the automatic thought record. So this is another thing that may be done where faulty ways of thinking are identified, understood, and eventually corrected. A client may write down situations where she had an automatic thought that is negative, including what she felt, the intensity of the automatic thought, and how she eventually responded. Then the client is made to realize how she should have reacted. This enables constant checks during maintenance and relapse stages in the change model that applies to alcohol use definitely. So another thing, next page. So ethical ways of decision making is also being enforced so that the client can make good choices in a well-guided manner. So not actually forcibly enforcing it, but at their own time, no? And then, so we use the White and Popovich ethical decision-making model. So this can also help the client who are mostly confused. Next slide. So what I personally use though is the local tool that we have in the Philippines called Palma Angeles Decision Making Tool of the Ateneo de Manila University. And next slide. So since referral is necessary in the practice, the need to make a directory on what is easily accessible as to services and facilities should be made available. Remember that the Philippines is an island nation, and there is actually problems with access. It is important to build one's directory with the name of the organization, the services they offer, contact details, location, target clients, admission criteria, referral process, and potential barriers, so that the patient that came to you for screening, you can actually refer them to the right physician or mental health professional. Then next slide. So this will be my last slide. Finally, a pharmacist should learn to take good care of himself during the screening. He may evaluate the risk through the patient history gathered, especially in ASI, where many notes are being gathered. So, for example, you observe poor compliance to medication. This might indicate risk like, for example, violence, although not generalizable. Please remember that. As interviewer, the pharmacist needs to listen carefully and patiently as many clients are confused and frustrated. Thus, they need respect and must be given full attention, like what Dr. Stewart previously said. Empathy is also needed when dealing with clients, as most of them are misunderstood and suffering. The pharmacist needs to understand that it is that if the patient is frustrated, it is not directed towards him and her. So things should not be taken personally. Always be calm and do not overreact. Let the client finish his responses. Let them talk. It should come from them. And then ASI would take an hour, so patience is actually a must. Lastly, be reminded that not all patients who have an alcohol problem are violent, and that sometimes simply listening well and communicating effectively is what is needed. Thank you very much for listening.
Thank you, Romeo, for introducing us the tools for screening alcohol, and I am sure that many colleagues will have a lot of questions. Now we are going with Dr. Corina Scutari. Since 2021, Dr. Corina Scutari is the head of the Department of Pharmacology and Clinical Pharmacy. He has published over than 100 scientific work and co-authored several books. Actively involved in teaching pharmacology and clinical pharmacy for pharmacy and dentist students. Corina, the floor is.
Hello, thank you very much for this introduction, Leticia, and thank you for the opportunity to participate at this important evening about pharmacological intervention of alcoholic consumption. And to know that according to estimates from experts in the field, the Republic of Moldova ranks among the top countries with the highest alcohol consumption per capita in the world. And according to the Global Report of Alcohol Consumption and Health, in 2021, Moldova recorded an annual consumption of 15.2 liters of alcohol per capita for individuals age 15 plus. with men consuming 25.2 liters per capita, while the female population consumed 6.1 liter per capita. Next slide, please. What are the risk factors of alcohol on the body? The following risks are that alcohol slows down the functionality of the central nervous system and thus altering the person's perceptions, emotions, movement, vision, hearing, and others. Also, long-term drinking can lead to heart problems such as cardiomyopathy, arrhythmias, myocardial infarction, hypertension, and others. Also, alcohol leads to numerous liver problems such as steatosis, hepatitis, liver fibrosis, cirrhosis, and alcohol in large doses leads to a weakened immune system. And to know that even occasional excessive drinking lowers the body's ability to fight infections and for up to 24 hours after intoxication. Next slide, please. The aim of our study was to determine the risk factors and medication management for alcohol dependence. Thus, the following objectives were outlined to achieve the goal. First one, to determine the amount of alcohol consumed, alcohol preferences, and the duration of alcohol consumption through life. To evaluate the medication for alcohol dependence, and to determine the role of pharmacists, not only of pharmacists, but also of clinical pharmacists in monitoring the treatment and prevention of alcoholism. Next slide, please. Alcoholism pharmacotherapy is only possible when the patient desires it themselves. Treatment is carried out in the hospital if the patient is in the state of severe intoxication with serious psychological and somatic disturbances like serious liver problems, neurological problems, and cardiovascular problems. The pharmacological treatment of alcoholism includes 3 stages. First one is detoxification therapy, gastric lavage, withdrawal treatment, and abstinence treatment. To know that detoxification therapy is the main emergency treatment stage involving the administration of vitamin complexes, nootropics, anxiolytics, and a lot of other drugs. Please, next slide. Long-term treatment of alcohol withdrawal and alcohol treatment, alcoholism, includes the following Food and Drug Administration approved medications like disulfiram, naltrexone, and encumbrance. Other medications are topiramate, gabapentin, antidepressive drugs, antidepressants for co-occurring depression, also tranquilizers or anxiolytics, and vitaminic complexes. Other slide. Next. So now that disulfiram, it's the only drug used for alcoholic treatment, and this drug inhibits aldehyde dehydrogenase, appears to be effective if compared with no treatment or when administration is monitored. A side effect produces disulfiram reaction neuropathy, and disulfiram is contraindicated in severe myocardial diseases in case of psychosis. And to know that these drugs, it is, or to avoid these drugs in combination, either in association with metronidazole or in patients with history of heart diseases and over age 60, or in case of severe hypertension. Next, please, next slide. Other very important drug is naltrexone. Naltrexone is opioid antagonist, so to reduce the reinforcing effect of alcohol. The long-acting injectable form is Vivitrol, and this drug has fewer adverse effects than disulfiram. It can be used during 1 year. Side effects are nausea, headache, dizziness, and dysphoria. Next slide, please. Also very important drug is encumbrance, enhances GABA reception and transmission, which are reduced by chronic alcohol exposure. It can be used during 1 year, has fewer adverse effects than disulfiram. As side effects, it can produce diarrhea. Next slide, please. Topiramate, it's a GABA enhancer, so to reduce the rewarding effect of alcohol. Systemic review, including 6 randomized clinical trials and total of 979 participants, showed that fewer drinks and drinking day, higher percent days abstinent, and less heavy drinking. A side effect produces paresthesia, anorexia, taste perversion, difficulty with concentration, and hyperchloremic metabolic acidosis. Please, other. Next slide. This is gabapentin. It enhances GABA activity. In a 12-week trial, gabapentin was associated with reduction in heavy drinking and increase in abstinence. As adverse effects, it produces dizziness. It can be used in association with other drugs for alcoholism. Please, next slide. And very important group of drugs are antidepressants for patients with co-occurring depression and alcohol use diseases. In a systemic review that includes 8 randomized clinical trials with a total of 389 subjects followed for 8 till 24 weeks, antidepressants medications had beneficial effects on measures of alcohol use with an effect size of 0.5 liters. The most frequently used medications are sertraline, fluoxetine, and escitalopram, and others. Please, next slide. This study followed a group of 90 chronic alcoholic patients with 1 or more of following liver diseases and cardiovascular diseases in the Republican Narcology Dispensary. And the group consisted of 50 patients studied based on observation sheets from department number 1 and 40 patients studied based on observation sheets from department number 3 of Republican Narcology Dispensary. Next slide. In the statistical analysis of group, we gathered general data on alcohol consumption, including beverage preferences, duration of consumption in years, the estimated average daily intake. And these data were evaluated for 90 chronic alcoholic patients hospitalized between 2023 and 2024. Please, next slide. Our findings indicate that the largest proportion of patients preferred wine, followed by those consuming distilled spirits or vodka, with the smallest group showing no particular preference. Please, next slide. And this study of the average daily amount of alcohol consumed, as reported by the patients, showed that the most of them consume less than 1 liter per day. And in the case of spirits or vodka, even 0.5 liters represents an amount that exceeds the physiological limit of the body's capacity to metabolize ethanol. The study of the consumption duration showed the following distribution: less than 5 years in 3.3% cases, 5-10 years, 10 cases or 11% cases, and more than 15 years, it is a higher percentage, it's 53%. Next slide. Out of the 40 patients admitted in 2023, 57% were readmitted once within the same year, and 17.5% experienced 2 or more readmissions. And these data indicate the relapses were frequent or very frequent in 75% of the cases. Next slide, please. The duration of treatment for the majority of patients was up to 30 days. Specifically, 48% received treatment for 21 days, 26% for 28 days, and 16% for 14 days. And 7% were discharged within the first 7 days. Next slide. The most important in emergency situation was detoxification therapy. After the analysis of our observation sheets, we determined that detoxification therapy was made 5-7 days. The drugs used were dextran, glucose solution, sodium chloride intravenously, and thiosulfate solution, and magnesium sulfate solution. Also frequently used with vitamin therapy for 15-20 days, like vitamin C, ascorbic acid solution, nicotinic acid solution, cyanocobalamin, pyridoxine, and thiamine solution for intramuscular administration. Very important B-complex solution, and folic acid for 30 days. Next slide, please. Also, for treatment of alcoholism are used mainly anxiolytics like diazepam, 20 milligram intravenously, or 4 milliliter intramuscularly during 5 days. Other drugs, clonazepam, 2 milligram 3 times per day, orally, and alprazolam 0.5 milligram 2 times per day during 30 days. Anti-alcoholic drugs are used in the Republic of Moldova, where disulfiram in a dose of 500 milligram per day for 15 days, then 250 milligrams per day for 15 days orally. And the other drug not approved by Food and Drug Administration, metronidazole, 250 milligrams, but the dosages are according to the scheme. Other group of drugs used in hospitals are neuroleptics as needed, like haloperidol, levomepramazine, and to know that very frequently used as a typical neuroleptic is risperidone, that produces fewer adverse effects. Antidepressant as needed, more frequently used, escitalopram 10 milligrams, venlafaxine 37.5 milligram, paroxetine 20 milligram 2 times per day, and in some cases amitriptyline. And for a long period of times are used nootropics, drugs that improve vascular perfusion and metabolic processes in the brain. The most important are piracetam, that can be used perorally or intravenously by intravenous infusion, and cinnarizine and vinpocetine. Cinnarizine during 30 days and vinpocetine during 10 days. Next slide, please. And as symptomatic therapy are used cardiovascular medications and hepatoprotective drugs. For hypertension and cardiovascular problems are used beta blockers like bisoprolol and metoprolol. Like calcium channel blockers, more frequently is used amlodipine, and ACE inhibitors like captopril and enalapril, and maybe other drugs. Hepatoprotective agents are used also in complex treatment like ursodeoxycholic acid and phospholipids, because I told that in case of alcoholism frequently appear such problems like fibrosis and steatosis. and in severe situations, cirrhosis. Next slide, please. These are some examples of observation sheets from the hospitals, from the narcological dispensary of the Republic of Moldova. And I want to mention that as anxiolytics more frequently used sibazon, it's diazepam and alprazolam. Also frequently used nootropic drugs like cynarizine, vanpositin, and piracetam. For detoxification, frequently used solution of glucose and magnesium sulfate or natri chlorides. And in case of psychosis, are used neuroleptics like haloperidol in severe situation, but in not so severe situation, a typical neuroleptic like risperidone to tranquilize the patient. And in complex treatment are used vitaminic drugs like folic acid and complex B vitamins. The next slide. Treatment with disulfiram and metronidazole. We analyzed what treatment are used in our hospital, and the most frequently used is disulfiram, commercial name teturam, in dose of 0.15 gram 2 times per day during 30 days. And in case of contraindications of disulfiram, frequently use metronidazole in different dosages. It is independent on patients and on the reactivity of patients. For example, mainly it's used in the dosages of 500 milligram per day, but other clinics, because we have a lot of departments in different locations of these clinics. And to know that in other clinics, when patients have psychological problems and psychiatric problems, metronidazole is used in higher dosages. For example, 250 milligrams per day, 3 times per day, 5 days. After this, 500 milligrams 3 times per day, other 5 days, and 750 milligrams 3 times per day, other 5 days. And after this, the dosages decreases 0.5 or 0.5 grams per day till 1 gram per day. And these drugs, it's very effective to treat the alcoholic abstinence. Next slide, please. The most important, we made an analysis what drugs very frequently used for patients with alcoholism. More frequently used are polyvidone solution for detoxification, dextran solution, magnesium sulfate, and also diuretics furosemide, and in association with the glucose solution. Next slide, please. The most important classes used in treatment of alcoholism in 2023-2024 were for detoxification treatment drugs, anxiolytics, vitamins or vitaminic complexes, and in association with neuroleptics, nootropic drugs, and cardiovascular and anticonvulsive drugs like gabapentin. Next slide, please. The treatment of alcoholic fatty liver disease included more frequently the following drugs like silymarin that has hepatoprotective and antioxidant effect, ursodeoxycholic acid that has anti-hepatoprotective and choleretic effect during 1-3 months. essential phospholipids during 1-3 months, and additional supplementation included vitamins like thiamine solution, pyridoxine, nicotinic acid, and folic acid. Next slide, please. And for long-term treatment of alcoholism are used mainly vitamin therapy. For example, for neuropathy, more frequently used is vitamin 1, B1, tocopherol acetate, in combination with folic acid, and also frequently used ascorbic acid. As nootropics for long-term treatment used piracetam during 3-4 months. And anxiolyticals or tranquilizers are used in small dosages like diazepam and alprazolam. And as anti-alcoholic treatment are used disulfiram and metronidazole, individually depending on the patient's psychosomatic condition. And very important is psychotherapeutic treatment and psychological rehabilitation. Next slide, please. Very important is the role of pharmacists and clinical pharmacists that can play in a very important role in enhancing access to evidence-based pharmacotherapy and in promoting medication education for patients with alcoholism. I want to mention that in the Republic of Moldova nowadays it is discussed the role of pharmacists and clinical pharmacists. We are the first stage in the development of this area of clinical pharmacy. And nowadays our department activates a lot of clinical pharmacists, and one of clinical pharmacists activates it the narcology dispensary of this hospital of narcology dispensary. And to know that the role of clinical pharmacists, it is very high to evaluate the clinical medications, to evaluate the interaction of drugs used by doctors, and to avoid the adverse effects of different drugs, and to know that the role of clinical pharmacists is higher, because after the implication of clinical pharmacists, the pharmacotherapeutic problems like interactions and pharmacovigilance, it decreased. And thus, I hope that this area will be more developed in our country and in other countries. Next slide, please. And in conclusion, I want to mention that the most frequently used groups of drugs in alcoholism in the hospitals of Republic of Moldova are the following drugs like nootropics, anxiolytics, antidepressants, and also detoxification therapy in association with cardiovascular medication, hepatoprotection, and vitamins. And clinical pharmacists play a crucial role in improving the outcomes of pharmacotherapy for patients with alcoholism, particularly by identifying the drug interactions, adverse effects, and evaluating those of high risk of alcohol abuse. Thank you very much for attention, and I hope this information will be helpful for you. And I'm waiting your questions. Thank you very much.
Thank you very much, Corina, for a fantastic presentation. Now, I have only one question because we are just on time. And the question is going to Mr. Dahl. I really want to know what actions can individual pharmacists take at the community level to address alcohol-related harm, including prevention, education, and support for the patient, particularly in the low-income countries, please.
Thank you very much for that question, Letizia. It requires a lot of answer. I try to be short. I think we need to distinguish between three different things here. One thing is in the pharmacist in his or her professional capacity, and the second is then in the institution that the person is working, and third is in the community that he or she lives. And I think pharmacists can contribute on all these three parts. And first and foremost, of course, in the role as a pharmacist, if you are now talking about either in the pharmacy or in the hospital, you are in the front line. Of course, if you are in a pharmaceutical industry or in government, it's a different type of role you will play, but also you can play important roles there. But if you concentrate on the pharmacies and in the hospitals, I think you are really in the front line, and you are handing out medications that can have grave interaction with alcohol. So I think that's one thing, but you are also in the front line to discover and see what if there might be additional problems that can be addressed here. And we talked about brief intervention. Treatment is probably it's a different thing, but especially brief intervention picking up, and it depends the context of the pharmacy and how much you can. What is the competency of the pharmacy to operate on these issues? That is really an important question. But the assist was mentioned here, and even we have an assist C, which only consists of 3 questions. And if there is a relationship with a customer that this is safe, non-stigmatized settings, it might be that you can initiate dialogues, which can lead, if it's clear that some additional help is needed here. I think there is. But also on general information, in a non-personalized matter to customers and through the institution to develop pamphlets or have pamphlets. That's another way to do it, as in the professional capacity. In the personal capacity, with your competency and understanding of the pharmacological aspects of ethanol and how it affects individuals and society, you could really be a huge advocate for putting in place measures that can change the culture in the society and the community that you live in. And then you can also push your organization and your associations to be more involved in the national level and perhaps even at the international level to develop good policies that can be implemented and help then in the implementation. So that are. And finally, you can yourself, not the individual, but the associations, which you did now recently. You launched the Tobacco Association Manual yesterday, pamphlet, an excellent example of how the pharmacists can contribute. And this can be also done at the local level. And there's enough information that you can translate into your setting, whether language-wise or cultural-wise, to have it available for the customers. So I think that's a few issues, but there are many, and also data, data collection. We need a lot of data, and you are again in the front. So I just, if you start thinking about it, there's so many areas that the pharmacists and the FIB and all associations and the institutions, the pharmacists themselves, can contribute in this area, and you are really needed also. We need more people being involved. This should not be a specific topic for specific organizations or people. This is a broad public health problem. It needs a broad public health solution.
Perfect. So we have to work together to about this theme, and I think that we have taken a lot of message for this presentation. Because we are 3 minutes past, I am going to pass to let you know that we are going to have our Congress in Copenhagen, and you are going to also have this event is going to be uploaded in YouTube. Then this Congress is going to be in event.fip.org, and the Congress is going to be in Copenhagen in the September, and the theme is Pharmacy Forward, Performance, Collaboration, and Health Transformation. And in the last slide, we have some important calendar for abstract submission and the sub-teams we're going to have in Copenhagen. And I want to thank you all of the speakers, and thank you all of the people who was listening and who will listen us. Thank you very much. Bye-bye.